Welcome back to last session of Pain Clinic. Now we'll be discussing a lot of cases here, and we will not be talking too much about why we are using these drugs, but we will just discussing mostly on the P drug list, the personal drug list. And now you should all know that there's nothing like a better NSAID. You need not compare NSAIDs with each other. No, it all depends upon the clinical condition of the patient, the severity of the pain, the cause of the pain, and then you decide the suitability of the drug, and for that moment, for that individual. So it differs from individual to individual. It can differ in an individual from time to time of which NSAID to be used and so on. Now you should also know that there are too many me too drugs. We have seen so many categories of painkiller drugs, so it's so confusing. So the best strategy for prescribing any painkiller drug is to establish a personal drug list for a particular clinical condition, so that a particular drug clinical condition will have at least 4 to 5 painkillers listed, and then you select any one from that according to the condition of the patient and then prescribe it to the individual. So with that, I start this case-based learning session, which is quite interesting. Most of 16-17 cases about general pain management with the drugs that we have seen in the earlier session. Case 1.
So in this case, a young student, she's complaining of headache for about a week because probably she's stressed out because of her studies.
Yeah.
Now this kind of headache is a typical tension headache, and the management is a non-steroidal anti-inflammatory drugs. Please remember that headache is not always due to tension headache.
Yeah, it can
There
be
are a lot of other conditions which may cause headache. So please be careful about this. But headache which is occasional and occurring because of stress can be safely treated with drugs like paracetamol, 500 milligrams, aspirin, 50 milligram PRN, diclofenac 50 milligram PRN, and aspirin in doses of 650 milligram to 1000 milligram PRN. The only point to be cautious is to avoid using too much of medication, because too much of pain medication may also lead to headache. There's something called medication overuse headache or rebound headache. So sometimes you're taking too much of medication that is producing headache. So the general rule to be followed, that you should not take more than 9 days, consecutive medications, or anybody with more than 2 doses requirement per episode. These are the people who should look for, a consultation with a doctor.
Okay. So that is case 1 about tension headache in a university student. The next case is case number 2, which is a 50-year-old otherwise healthy executive who visits dental clinic for toothache. Now toothache is also emergency because of the pain associated, and of course we can use a non-steroidal anti-inflammatory agent. Now toothache also sometimes come with inflammation also, so you can use ibuprofen or naproxen also can be good anti-inflammatory along with analgesic. But anyway, ibuprofen is my choice here, 600 milligrams 6 hourly. In children also you can use ibuprofen in syrup form. Of course, you can always use paracetamol as an additional pain control if needed. Or we can use plain paracetamol, but we can increase the dose to 1000 milligrams. So that can also be done to reduce pain, because it's also a good analgesic drug. If the pain is very severe, then give the patient the option of narcotic medications. But you need to really ask, this is all about theory, you need to ask a dentist per se whether they use a narcotic medication at all. But then as far as theory is concerned, you can of course give them a choice of narcotic medication along with NSAIDs for control of pain in a dental case. You want to add something?
Yeah, basically just to differentiate case 1 and case 2. The case 1 was just about pain.
Yeah.
In case 2 there is some inflammation as well.
Yeah.
That's why
the choice of agent has different, because paracetamol is not a good anti-inflammatory, just analgesic. Whereas with dental case there is slight inflammation. In fact, inflammation followed by pain, so it goes hand in hand. So maybe the choice has changed from paracetamol to ibuprofen in this case.
In this case, that is case number 3, elderly woman is suffering from acute low back pain. just for a day. And this has happened because she had lifted some heavy things. Now this is very common, lifting heavy things followed by a very bad backache.
Yeah, especially spasm.
Muscle spasm,
Yeah.
as rightly pointed out by Dr. Amaya. She is otherwise healthy. So a point to be noted initially is that backache may be as a result of a muscle spasm.
Yeah.
It may be because of the nerve roots are being entrapped. It may be because of the degeneration of the bone or a fracture of the spine bone, that is the vertebra, or it may be also suddenly occurring maybe as a result of the intervertebral disc which is collapsed. So this is something we must be very careful. So if there is backache which is very severe, which is associated with some tingling, numbness or other paresthesia, what we say occurring in the legs, or it's terrible, it's not being relieved by any other means, please do consult a physician. But for ordinary pains which occurs either because the muscle has gone into spasm, or because you stressed yourself too much, drugs like ibuprofen, paracetamol, naproxen and other COX-2 inhibitors can be used in treatment of pain.
COX-2 inhibitors again need to be used only for a short period of time.
Yeah.
With naproxen, maybe additional point is also anti-inflammatory.
Yes, sometimes you need some anti-inflammatory drug in this situation, so you may use naproxen as well. But sometimes the muscle spasm is to be relieved.
Yeah.
So as mentioned, the
earlier we need to combine the muscle relaxant with the NSAID.
Yes.
So combinations of chlorzoxazone, I hope the pronunciation is correct, or phenylephrine or tizanidine with ibuprofen, paracetamol, naproxen can be good choices.
So there are various combinations available. On the other hand, if you are not being relieved by medication alone, you can also apply the gel forms which we have mentioned earlier.
Even sprays are available.
Yes. So you can use both the tablets as well as the topical application along with the muscle relaxant, and that should produce very good relief of your.
Anyway, we are just talking here with the pain perspective, so we are not talking of the additional treatment that goes for these individuals. So just looking from pain aspect, we are just discussing drugs. It's not a full-fledged therapy discussion about backache, neither with the earlier two cases that we have seen, and neither we are talking more on the diagnosis part. We just are talking in terms of drugs, especially for pain for these cases. So case number 4 is about a 45-year-old who has intermittent low back pain for the last 2 years. There is a difference. That the earlier case was sudden backache, but here it is for the last 2 years. There is no radiation of the pain. His symptoms get aggravated when he lifts heavy bags in cold weather, changes his place of sleep, and after traveling long distances in his car. You can use paracetamol because it's a good drug, gastroprotective, because he's a chronic patient of pain. Now the chronic pain can be due to various reasons, ankylosing spondylosis, rheumatoid arthritis, or it might be just some people have back pain because of bad posture.
It could be due to the sacroiliac
ligaments being, or maybe a trauma which has occurred a few years back, and people tend to get this backache, especially people who have the height is more, also tend to get this kind of a pain and so on.
Often the exact cause
is not known.
It's not
they say the very small muscles in and around the spine are the ones which get weak, and over a period people start getting pain. And he's a 45-year-old, so I think that it's mostly due to the posture, that his sedentary lifestyle, maybe obesity is one of the reasons again for pain.
If you sit beside the computer for around 6 to 8 hours a day, you might end up with backache. And that's why people say that you must get up every 1 hour and travel here and there.
And then if you exercise also. But anyway, what we are also concerned here is that the patient should not be taking these drugs, whatever mentioned here, for a very long period of time, because NSAIDs can bring about a lot of problems as far as gastritis, renal problems and so on. So even though OTC drugs, try to use them whenever necessary. Paracetamol can be a good choice because it is gastroprotective, but again, if this patient is having a more of inflammation, then maybe we stick to piroxicam, which is once a day anti-inflammatory NSAID, or we can go on with few other drugs which are high potency like ibuprofen, diclofenac or naproxen with additional anti-inflammatory property for these individuals. So my choice still remains as paracetamol, but then again if inflammation sets in and then that's the cause, then maybe piroxicam would be my choice.
So I think if you want to make a choice, if it's a muscle spasm
Yeah.
which is bothering you,
Yeah.
it would be better to use paracetamol plus.
If the pain is high, maybe ibuprofen or diclofenac can help him
Especially if you
additionally.
think it is an inflammation as well.
So it's so confusing, I cannot point out to one single agent even in this category. People will be having so many different choices of their own. So that's what I said, you need to have a P-drug list of your own. Depends upon the situation, what you want to use but anyway, need to combine a muscle relaxant. Now here I said clozoxazone, that doesn't mean that should be the agent. You can always use orphanetrin or some other agent. You can of course add an opioid analgesic if the pain is very severe, but that too you need to assess the individual and then think about adding if at all, because codeine has a property of addiction, abuse liability. So again need to think when you need to add these drugs to these individuals. Case number 5.
In case number 5, there's a young football player who gets ankle injury, and the
Yeah.
ankle is swollen and tender, and most of the injury is soft tissue injury.
Yeah.
So whenever there is soft tissue injury, then what we need to prescribe is just a pain reliever along with a anti-inflammatory
Yeah.
drug. So that is why most of the prescription is naproxen, diclofenac or ibuprofen. Now if the pain is very severe, and especially if you need to give an injection of the non-steroidal drug, probably ketorolac may be
Yeah, because it's a potent analgesic.
It's a very
drug.
potent
An
analgesic.
NSAID, yeah.
Yeah, and it is the choice often in the emergency departments. And here in this respect at least, the NSAIDs are better than using just simply paracetamol. Paracetamol may not be help you much in this.
It can be add-on if you want, but not
Yeah.
as something which is primary in origin.
Exactly, and again, the addition of a gel of diclofenac.
Yeah, or a spray, local applications might help.
May help.
Yeah. Now case number 6 is about a 25-year-old woman who suffers from sudden onset excruciating left flank abdominal pain. So it's abdominal pain. Now on examination, maybe ultrasound was done for her and a 5 mm left-sided ureteric stones. Now ureteric stones are of various types. That is, this discussion is not about ureteric stones, but most of the ureteric stones do cause pain because they have spikes, and when they move through the ureter, they can cause pain, and it's a very severe pain. In fact, that's the classical way of describing this pain is that how the fish moves, violent movements when you take it out of the water. That's how especially the pain is. So otherwise she is all healthy and her renal functions fortunately are within normal limits. So what we need here is a potent analgesic drug, and my choice here is ketorolac injections. Of course you can give ibuprofen or an naproxen. Parenteral use is what is preferred. People might require tramadol or fentanyl as an opioid analgesic if they do not get relieved by just putting them on NSAID. You need to avoid NSAID if you want to do any intervention or a surgery for this patient, because NSAIDs give rise to bleeding. So even if you want to use these drugs, better to avoid. You can maybe put the patient on some opioid analgesic in that case. We do not want to use any spasmolytic drugs, especially anticholinergic drugs. They are not supposed to be used. People have the wrong notion that you need to use them to reduce pain, especially which occurs with renal stones or ureteric stones. It's not to them. We need to opt between an NSAID, a potent one, parenteral given, or opioid analgesic.
The only point to note here is probably the oral route is not a good route
Not
to
a,
use.
because it's an emergency situation.
It's very severe pain.
It's severe pain, and the absorption might not be good, and drug might require some time to give its action.
Yeah, so intramuscular, intravenous is the preferred route.
Is the preferred route in this condition. So moving on with case 7.
Here, a fat fertile female of 40, typically a patient of gallbladder pain.
Yeah.
Because she is diagnosed with having acute cholecystitis, which means there's an inflammation of the gallbladder. Now here again, therefore, because of the inflammation, we would prefer that we use an anti-inflammatory drug.
Yeah.
Ketorolac, naproxen are the drugs of choice.
Yeah.
Again, we would like to use the parenteral route because it's a severe pain.
Yeah.
Now, why ketorolac and naproxen may help in this situation? Because we have realized that release of prostaglandin results in gallbladder distension. Therefore, inhibition of these prostaglandins may actually help in elevation of this symptom. In severe situation, we might need to add an opiate.
But a caution here that opioid analgesics also cause biliary colic. They cause biliary spasm.
They may cause biliary spasm, but on the other hand, if it's just acute cholecystitis with no biliary involvement, there's no contraindication to use of opioid analgesics.
And again, no to antispasmodics even.
But in acute cholecystitis, if it is only cholecystitis, which is the gallbladder involvement, and no involvement of the bile duct as such, hyoscine can be given in this situation. Hyoscine or buscopan. But if we suspect that there is an involvement of the biliary duct as well, then the antispasmodics are actually
to be contraindicated
or used with caution.
So case number 8 is about a 45-year-old executive who is shifted to emergency room with chest pain and breathlessness. He is diagnosed with anterolateral myocardial infarction. Now we have talked about this in the past. Of course, we require nitrates and so on as rescue medications. But then again, morphine is one of the drug of choice in this case to relieve pain and anxiety in this condition. Morphine helps dually, it reduces pain, and the second one is also shifts the fluid from the pulmonary segment to the systemic region, so it helps in that way also in patients of myocardial infarction. So morphine, in other words, decreases preload, so that's also a good way of managing MI cases. Studies have indicated that early administration of streptokinase and glycerin trinate also relieves pain. So yes, we start with in fact nitrates, add on to morphine, and then streptokinase will be required eventually. That's again a big line of therapy which goes for MI, but we need not enter into that at this point. You need to add something? Okay, so that's just that we need to know that opioids are used here, especially with myocardial infarction, with dual advantages of its use in this condition.
In case number 9, we have a patient with trauma. Either it may be a soft tissue trauma, it may be fracture, or there is severe pain and we do not know the cause. It is very useful to use a pain rating scale in the emergency to know whether his pain is mild, moderate or severe, because the choice of the analgesic will depend on how the severe the pain is. For example, if it is a mild pain, we can do with non-steroidal anti-inflammatory drugs. If it's a moderate to severe pain, then we need to add opioids for the pain management. Now, it's very important to manage the pain of trauma very effectively, to increase the comfort, to decrease the morbidity, and to improve long-term outcomes, because it has been shown that if trauma pain is not resolved at the earliest, then there might be certain side effects which may result in chronic pain, in psychosocial behavioral problems and other problems at a later time. So the drugs that can be used may be non-steroidal drugs, it may be the weaker opioids like tramadol, it may be the opioids, it may be also the adjuvants. So it depends upon the amount of pain and also the relief of pain obtained. In orthopedic pain, often splinting and traction can reduce the pain. So we must also remember the additional therapy which can bring down the pain. So immobilization is one way of bringing down pain where there are long bone or even fractures of long bones. So a combination therapies is often very good as well. So a combination of non-steroidal with morphine or a combination of morphine with adjuvants like clonidine may go a long way in relieving pain. We must also remember that we need not give the patient pain relief just by parenteral routes. We can also use other routes like the epidural route, and in case a patient is coherent, intelligent and an adult, The patient may also be prescribed a patient-controlled analgesia, which is a much better way of relieving pain when the pain is severe, because the patient is controlling his own pain, and this reduces the amount of analgesic being used and also gives a better relief of pain.
Yeah. Case number 10 is about an 80-year-old man with metastatic prostate cancer to bones. So he is in pain and agony and requires drugs for palliative drug relief. Now here we are talking of cancer related pain, and we have a WHO step ladder management of how we need to treat these individuals. So we start with NSAID. A choice can be a potent analgesic like ketorolac, and we then move on to opioids, maybe a weaker opioid first of all like codeine, and then at the later stage we might require a few others like morphine, or still potent than that would be a fentanyl. A combination of the above two can also be done at step 1, 2 and 3 depending upon the need. Transdermal fentanyl lozenges and so on, we have discussed that in our last session, can be one of the good drugs, especially with severe pain related to metastatic cancer. Now this slide here shows the steps of WHO approved management of pain. Step 1 is non-opioid way of management like aspirin, paracetamol, weaker NSAIDs plus minus adjuvants. Adjuvants we already talked of that. The step 2 is weak opioids for mild to moderate pain plus minus non-opioids plus minus adjuvants. So here we can use codeine plus NSAID plus adjuvant. If the pain persists and is increasing, then we want to increase we want to use something which is more potent like morphine or fentanyl plus or minus a non-opioid. A very potent analgesic here would be ketorolac plus minus adjuvant for pain. Anyway, whatever it might be, the pain control should be achieved at the end of the day. So that's the step ladder way of managing pain, which is approved by WHO. You want to add something on this? That's fine. So the case number 11.
Here, a 60-year-old man is having pain in the right knee joint for a year, and pain is aggravated by walking and climbing stairs, and particularly in winter. He has a locking sensation of the typical, knee joint, and he's been diagnosed as osteoarthritis of the right knee joint. Now, when a patient is suffering from osteoarthritis, then the choice of medication is very important, because this is a very chronic situation. So here you start off with more safer drugs, which are good analgesics like paracetamol. And if there is an acute event, for example, you are having a moderate relief of pain.
Because in this chronic diseases you will have up and down patterns.
Sudden increase in pain sometimes. Then you can either add codeine or tramadol. Both of them are weak opioids.
But just again a cautious choice is that they might prefer an opioid analgesic because of its abuse liability. So
because of its abuse liability, I think it's better that opioids are prescribed only at a later stage. Later stage. So weaker analgesics followed by stronger analgesics. So followed by ibuprofen, diclofenac, naproxen. In case you want a once a day drug,
pyroxicam, which is also anti-inflammatory action along with analgesia.
And of course, there are a lot of non-pharmacological methods to reduce pain. At this point, I would like to bring to your knowledge about the American College of Rheumatology, which mentions that a patient with hand, the osteoarthritis of the hand, the drugs to be prescribed are either topical capsaicin, topical or oral non-steroidal drugs, or tramadol. So no opioids or no intra-articular drugs for patients with hand osteoarthritis. On the other hand, patients with knee or hip osteoarthritis, these patients may be prescribed anti-articular injections of steroids. You start off with your topical and oral non-steroidals or acetaminophen, and you can build on, for acute and chronic situations, you add tramadol. At the same time, you can also use intra-articular steroid injections for relief of pain. The usual, the protocol is therefore the non-steroidal, which are weaker like paracetamol, followed by stronger drugs like naproxen, followed by addition of tramadol or codeine for acute situations, and intra-articular steroids for hip or knee osteoarthritis.
Yeah. Case number 12 is about rheumatoid arthritis case and pain management. Now we are just looking from pain management of RA. So again, NSAIDs, potent anti-inflammatory, potent analgesic to be used here. So my choice here is ketorolac, naproxen, diclofenac. Maybe piroxicam, which is once a day, good anti-inflammatory, can be also ITS addition. A few other things like ice pack and can also be given, but that's an optional thing. And you need to continue at least for 48 hours if the patient gets pain. So you want to add something?
Yeah, I think anybody with a chronic pain of osteoarthritis or rheumatoid arthritis must be very careful and look out for the side effects of the non-steroidal drugs, and should bring it to the notice of their consultants once they come into the picture, and should stop the medications and consult the physician,
because this is going to be lifetime scenario for them for use of these drugs, so need to be careful. Now again, we are just looking from pain perspective and more, we are not looking into other drugs for management of rheumatoid arthritis. Okay, so case number 13, 1 and 2. Now here is a common problem that mostly people will face as a doctor is person with ear problems and eye injury and eye pain. So for ear problems, you need to treat here, let it be an eye problem or ear problem and the pain associated. You need to treat the primary cause because without treating it, it's not going to solve the problem. But as far as pain is concerned, a combination of NSAIDs plus a steroid ear drop, addition of antibiotics and oral drugs may be necessary if necessary. So I opt again for ear drops with NSAIDs for ear problems. If it is a wax problem, you need to have drugs which can get the wax out, or you need to manually remove the wax from the ear and so on. Especially with eye injuries, local anesthetics, we need to use a local anesthetic plus a potent NSAID, flurbiprofen, which is commonly used, ketorolac, ketoprofen. Now these three are available mostly as eye drops. So flurbiprofen, ketoprofen are used because there are a lot of GI problems. So maybe they use this as topical ointments, that topical drops, especially with eyes. Add antibiotic or oral drug if at all necessary. So that's again how you need to treat pain related to eye and ear problems.
Going on to the last case.
No, we still have few.
Sorry. So we go to the case 14, where you have a patient of fibromyalgia or muscle spasm, pull or injury. Now, this kind of problem is to be treated with again the non-steroidal drugs plus the muscle relaxants we mentioned earlier. So it could be combinations like naproxen or phenylephrine, ibuprofen, chlorhexidine, paracetamol, tizanidine.
Well, these are few combinations. Of course, you get we have a lot of permutation combinations with even doses. You have few combinations where paracetamol is less or phenylephrine is more. The others will have more of NSAID, less of muscle relaxants. So depending upon what is available locally, what you are aware of and what is your experiences, you need to administer drugs accordingly for these individuals.
One more word about fibromyalgia is that this is a chronic problem, and often after using the non-steroidal drugs, they do not seem to relieve the pain anymore. So the next step would be use of codeine or tramadol. And there may come a time when even codeine and tramadol are unable to relieve pain. So in this case, antidepressant medications are added on to relieve the pain.
That's a good addition to the current treatment which is listed here. Case number 15 again, I think because this is a foolproof cover that we are talking of, so dysmenorrhea comes as a separate case. So women with dysmenorrhea, and we are talking just of pain relief here, we are not going to talk of other medications which can relieve the primary cause for dysmenorrhea. Of course, mefenamic acid is one of the good drugs which is available as tablets and syrups and which can be given. But then again, you can always opt to give ibuprofen, diclofenac, paracetamol, even naproxen. Etoposide is one of the good drugs nowadays, which is selective COX-2 120 mg OD. That is good for pain relief as far as dysmenorrhea is concerned.
One drug not mentioned here, nimesulide.
Nimesulide.
I think nimesulide is also a very good choice.
Good choice.
Because
good choice.
the side effects of
Yeah.
nimesulide is much less.
Yeah, but since it is banned in few countries, maybe we need to exercise some caution. But then again, if it is available, can be of use, especially with dysmenorrhea. The last case is about neuropathic pain.
So neuropathic pain is a different kind of pain where the mode of production of pain is different, and often the conventional analgesics like the non-steroidal drugs and the opioids are not effective in this kind of pain. No single drug probably can relieve neuropathic pain, and often we have to apply a multimodal approach. And as discussed earlier, anticonvulsants were discussed under the adjuvant therapy. So anticonvulsant drugs, antidepressant drugs, which are particularly the TCAs, that is the tricyclic antidepressants, and the serotonin receptor reuptake inhibitor.
Yeah.
These are the classes of drugs which may be added together. Of course, we have also mentioned alpha-2 adrenergic agonist drugs like clonidine, and there is a very good drug called dexmedetomidine, which is now the recent drug to be which is being used in place of clonidine. So these are the different drugs which are used in neuropathic pain. Local anesthetic agents, again, either used topically or used in various forms of blocks, may be sometimes used when pain cannot be relieved by other means. Opioid analgesics can be used, but they are only for short-term therapy when the pain is very severe. Steroids have been tried out in neuropathic pain, and there is a role of steroids in neuropathic pain as well. And on top of that, the other lifestyle modifications, physiotherapy, go a long way in relief of neuropathic pain.
The important point to be noted is that we are not using a NSAID. Like it is the first case we are not using option of NSAID.
Yes.
It's mostly now the first start would be something of antidepressant, anticonvulsants. So pregbalin, gabapentin, or maybe amitriptyline. These are few choices which are with us for management of neuropathic pain, and of course we have few others which are listed. So that can go hand in hand, especially for neuropathic pain and so on. So that was I think all about pain and pain management and drugs for pain. I think we did extensively 3 sessions, starting with physiology, then going on with analgesic drugs for pain, and the last is, of course, I think it covered most of the cases related to pain. 16 cases. I think too big of information to be captured in one session of a CPN. I hope that they listen it more than once to get what is in there and what we actually have talked about, to get the knowledge of how to manage pain overall. I will thank Dr. Susmita again for all these 3 sessions that she is with us and discuss actively about pain management. I hope you will like this session. Thank you, and do subscribe and enjoy listening.